experiences. I think it's great to be really listening to the senior experience and advice, but as they say, you know, with these sort of rapidly evolving times, doing that sort of peer learning, which I hope this session will continue to encourage for many years to come. I think hopefully you are forming many of these social networks, which will be invaluable for your careers. We'll be able to facilitate that further. So today's session is really, you know, focused. I think most of you heard my webinar. Hopefully, I think I gave sort of a really high-level talk about recruitment and retention. But now I think it's really important to hear, you know, from each other. And I drafted a couple of innocent people who didn't have the heart to say no to me. So I really want to thank Nicole and Yasmin. But I think what I'd like to do today is to just go ahead and really have them each tell their stories a little bit, you know, share their, you know, joys and I think challenges with recruitment and retention, how they sort of have pivoted their vision. I think all of you had really amazing stories, but I think they had some particular unique pearls to highlight, which I hope all of you will find helpful. So I think actually where I'd like to sort of begin is, you know, each of you sharing your story, you know, about becoming a clinical trialist. And Nicole, I know you talked a lot about infectious disease, but you actually went in with a different idea. You actually wanted to do traumatic brain injury, and then something happened literally on the road trying to do your study. I think you had it funded and everything. So walk us through like how you became a clinical trialist in infectious disease.
Well, one of my favorite quotes is, "The best journeys are not always in straight lines," and that has been true of my life and career. So walking back a little bit, I did a combined residency in internal medicine and pediatrics, and then I followed that with pediatric critical care. Was interested in neurocritical care, but there was not a pediatric neurocritical care fellowship at the time. But I was eligible for adult neurocritical care because of my internal medicine background. So I did an adult neurocritical care fellowship, and then was hired actually at Nationwide Children's Hospital in Columbus to come 100% clinical appointments to come and start the neurocritical care program for peds there. Which I said yes to, but then I also said, okay, but I'm also a global health pediatrician, and I need to incorporate part of that into my career as well. And they were kind of like, yeah, okay, as long as you start the neurocritical care, you can do whatever you want. So got there and actually spent the first 5 or 6 years of my career starting the pediatric neurocritical care service, and also started the global health training program for the residents at Nationwide Children's Hospital. And it was actually, I had of course dabbled in research as a fellow, as a Hall Fellow and a student. But it was actually during those first 5 years where I realized how much I loved research, because even though I was extremely busy with a full clinical load and starting 2 new programs, I actually spent every spare minute I had doing various observational trials and other things in traumatic brain injury, which, having trained in San Diego, there was always a lot of traumatic brain injury there because the weather is always perfect. And so after those programs were up and running, I thought, okay, I want to make a run at exploring this research a little bit more. And so I also wanted to marry my passions, which were neurocritical care and global health. And so I applied for a Fulbright grant to go to the Democratic Republic of Congo and study epidemiology of TBI in that setting, and then also I do a lot of transcranial Doppler ultrasound work to see if we could use that approach to help with neurodiagnostics, neuromonitoring in this resource-limited setting that doesn't have a lot of the things that we had in America. So this is where the pivot happens, because I get to rural Congo, which is where the Fulbright grant was awarded to me. And what I had failed to recognize when I wrote the initial proposal was that there are no roads in the Congo. And because there are no roads, there's also essentially no traumatic brain injury. And so I'm there for my Fulbright stint. I've got my husband. At the time we had 2 kids. My kids are there. We're all there. I have my TCD equipment. Everything is there, and I have 0 patients and will have 0 patients. So I looked around and I was like, well, actually knew about them. And so pretty quickly just said, okay, I'm going to spend my time using TCD to further investigate cerebrovascular hemodynamics and genital neuroinfections. And so did that, and that was almost 10 years ago now, and have just fallen in love with it. It's a relatively unstudied portion of pediatric neurocritical care, so I feel fortunate to be able to try to fill that space.
That's really great to know. I think I would just like to see some recruitment numbers. So it was good that you were kind of willing to adjust. You didn't have to call the program officer to change your specific aims dramatically. So I think
that's the fortunate thing. The interesting thing about the Fulbright is it's more interested in developing long-term scientific relationships with the folks on the ground. And so they were very happy for me to switch my focus of research as long as I was still keeping those relationships developing, which I think as we'll see for the rest of this time, that actually has proven true. So I think they're okay, even though I won't hard right.
Yeah, and some people have done a few U-turns and hard rights, but it's great to hear about that. And I think Yasmin, well, I think Nicole, your term was sort of driven by external circumstances, but Yasmin, I think yours was a little bit sort of combination in internal and external drivers. You got a career development award. It was a bit more observational. I think it'd be nice to hear about that. But I think somewhere along your pathway, both through your mentorship, but also sort of an internal drive, right, to figure out how to treat patients. Your observational research inspired your current CTMC clinical trial, which we've heard a bit about. So maybe you can share with us, how you kind of grew your career as a clinical trialist, albeit you started off in observational research.
Yeah, it's always hard to go after Nicole because she has such a colorful story, and mine, is in Ohio. It's not in Congo. Yeah, so I guess my origin story is I did my training at UPMC, which is very clinically heavy stroke program, incredibly heavy. So it was really in the trenches in terms of clinical work. We were kind of doing a lot of large vessel occlusion trials, and I had been around when people were kind of like looking at the research coordinators right before Brian access me, like, did you bring up this, XYZ trial, or did the residents actually get this and this on the CTA? Is this going to be a patient for so-and-so? But I wasn't, we were so clinically busy that I didn't have my own opportunity to really invest myself in research. It was really just something that I was helping the PIs kind of accomplish whatever was going on. Even our stroke template notes were very much like, so that you could get all of the baseline CRF info very quickly. And then, my last interview for fellowship was at Cincinnati, and it was back in the old days. We were actually traveling to places to interview, and I was thinking, oh gosh, I've never lived that far, like in that part of the country. Like, Pittsburgh is kind of like the most far west I'll go. And then I had a few people, including Lori Shutter, being like, you should really go there and check it out. They look at stroke a very different way than we look at stroke. And I went there and I thought it was amazing, just the amount of focus that was on clinical research. And I was offered the T32, and I ended up going there during COVID. 10 out of 10 do not recommend moving to a new place during COVID. Yeah. I got a lot of great mentorship. Obviously, Jim is in the room right now. Yeah. And Pooja Khatri and Eva Mystery, which she ended up coming as well. And I fooled myself into believing I could probably, enroll in trials well. So I got a career development award through the American Heart Association. I was talking about foundational grants yesterday. And I think the biggest thing that I learned from kind of being on the ground as a fellow, being involved in all of those StrokeNet studies, and having my own observational study is what is actually feasible in the acute setting. What actually makes sense? What actually can I derive in terms of information? What conversations can I practically have with patients and their family members? A lot of our patients are impaired, for example, and then things move very quickly. So I think that was a very salient information in terms of how to design a trial, how to make it as pragmatic as possible so you're not disrupting the actual workflow of what needs to happen.
So it sounds like a key part is that even though your career development award was observational, and you did carry that observational aspect. You were also sort of being, I guess, bifocal. You were also wearing the lens of a clinical trialist and looking ahead. How did you manage to balance that? You know, looking at what was in front of you from an observational standpoint, but then also kind of looking ahead, right, from a career trajectory standpoint. Because I guess it sounds like you felt like internally there was sort of impetus to go towards the treatment end.
Yeah, so briefly, I think the Career Development Award was trying to study or at least come up with at least a possible neuroimaging biomarker of no reflow and large vessel occlusion stroke. And so I kind of twisted that into my ultimate career goal, was to study neuroimaging biomarkers in the acute stroke setting. And so that's kind of how that naturally flowed into itself.
Yeah, and I'm really glad you actually mentioned, you know, StrokeNet. I hope everybody had the chance to listen to the webinars about these network recruitments. But it can be really intimidating, I think, when people are more junior investigators in terms of how to get integrated. So I want to pivot now a little bit about recruitment infrastructure for clinical trials. So just sort of coming off what you just shared, you know, can you tell us a little bit more about your experience, like being a StrokeNet site, like, you know, as somebody, right, getting started, right, during a key moment of your career, thinking about your first, you know, clinical trial, you know, what did you find helpful in terms of working with the network? You know, what were some challenges that you didn't expect? What are some tips you may want to give to some of your colleagues as they start to navigate, right, these networks, as we were talking about how to get some, you know, our folks here, you know, taking their CTMC trial into a network?
I think number 1, 2, and 3 is probably mentorship. When you're part of a network, people know each other and they can help you kind of set up relationships with key stakeholders for whatever you want to do. Also, the amount of resources that you have. If somebody doesn't know the answer to the question, they can at least refer you very easily to somebody who will know the answer. So I think that's probably the main things.
Well, that's good to know. So it sounds like, you know, they were really helpful. There's challenges, but mentorship is the key. So not just trying to DIY it sounds like is the most important thing. Okay, well, you know, Nicole, I'd be curious to hear about how your mentorship experience was, because, you know, you probably, as you just said, had to build your research infrastructure from ground up, and I think one of the topics I really enjoy talking to you about, you know, as somebody that does community-engaged research, was learning from you about, you know, using your community relationships, as that's what the Fulbright was all about, to build that recruitment infrastructure for what has turned out to be a very successful trials launch. So share with me a bit of your insights. You know, how did you, you know, build those mutual relationships, you know, to get communities that maybe had never even heard of research to be in research, doing research, and based on what you're telling me, actually enrolling and buying into research.
Yeah, I mean, there's a reason it's taken me almost 10 years to get a bunch of sites up and running. So essentially I walked into a hospital in rural DRC, to a place that I had never done any research at all. And so knew that a key aspect of even getting started would be to make sure that the leadership understood what the objectives of research were and what the advantages and potential challenges of doing research were. And then initially met with the hospital administrators, the hospital medical officers. Everybody was really excited and on board. They encouraged that I meet with the physician staff as a whole, so we had a series of meetings with the physician staff as a whole. It was during those meetings that it was pretty clear there were 2 specific individuals that were really excited about the idea of research, just based on the questions and things they were asking, so started to engage them more one-on-one to do additional education around it. And then the hospital leadership themselves was like, you know, the actual issue here is going to be the public, and helping the public understand what research even is. And so in the region, there are 10 local regions around the hospital, each of which is overseen by a village chief. And so we actually had a 3-day seminar where we invited all 10 of the village chiefs to the hospital. We talked through all of the components of what doing research looks like, about our specific ideas for critical care type of research, how that may impact their community members, why people people might even want to participate in research, which this was an interesting component of it, because in the local language there's not really even a word for compassion. So the idea of altruistically volunteering for research was absent. And so, we kind of had to carefully thread how we worded things to still get people interested. At the end of that 3-day meeting, we had 8 of the 10 village chiefs that were really interested in taking this back to their communities. So we gave them about a month. They went back to their communities. They went village to village within their communities, explaining everything that we were planning to do at the hospital, giving their verbal support, which essentially then translates to community support. And then we followed that people in the Congo get their news by listening to the radio in the evenings, sitting around. And so we started a series of nightly community updates, community bulletins to explain research and what we would be doing, when we would be opening, what they should bring their children to the hospital for. And then on the opening day, it seemed to have all worked because the patients started coming.
That really sounds amazing. So if I'm hearing you correctly, there was really a multi-layered process, really finding champions at every single level, both in the hospital level, as well as the local community level. Can you actually maybe take a moment, because I'm not sure people may be as familiar with trying to work with community leaders, in this case the village leaders you described it, and what that experience is like. You go into one village, I'm guessing you've seen one village, and everybody has different goals, interests, and even though they say they're interested, and even though you're even physically living with them and you're trying to, be amongst the people, it's still not the same. So kind of go into that a little bit more if you can.
Yeah, I think this is where I anyway quickly realized that I am not the expert in any of this, and so I relied very heavily on the local people that I was working with. Over the course of the month that the village chiefs were out sensitizing the community, we actually repeatedly sent a clinical officer is essentially the equivalent of a PA or an MP in the US. We had several of those already signed on to work to the research projects. And they would take motorbikes out to the different villages to kind of follow up after the chiefs had been there to gather further information, answer follow-up questions, make sure they were available. Fortunately, we finally started to have some cellular service in the area, and usually there was at least one phone in each area, so gave the phone number to the research organizing center back, and people would sometimes call with questions. So it was just truly just a individual level painstaking process where we just worked through as much of the people and community and leadership as we could.
That's great. We talk about precision medicine for treatment, but this sounds like a precision level recruitment. And I think for all the recruitment we do, right, it's never a one and done. It's really just making sure the door is open and stays open to the dialogue, because you need them to come back. But as you kind of say, if you build it, they will come. If you build it right, and then they keep on coming.
And I think that was the other thing to that end is, once participants did come and they were enrolling in research, we actually did exit interviews with all of them as they were leaving. A, to make sure they understood that they had just participated in research, but B, to also get their sense of needs or changes or how the process needed to look different so that they would continue to verbally support us within their communities. And one easy example is we heard pretty quickly that families had a challenge of not being able to get food for their families while they were hospitalized with their children for research, because they're not a hospital cafeteria. So we very quickly and easily fixed that by having a cook make food for the families while they were there. And then, so it's just taking the feedback and working on the easy fixes so that the individuals that participated in research verbally spread the word, hey, this is worth doing.
Yeah, and I think building that trust is really important. And I think we talked about, exit interviews, and that kind of brings us to the next step, right? You build all this infrastructure, and people start coming, and next thing you know is you've got to have some follow-up with them. It used to be stroke was one and done, but Yasmin, I think I want to hear a little bit more from you, about retention, because, acute stroke is no longer just acute stroke. So love to hear, we talked a little bit about some of the challenges of retention, because I guess unlike Nicole, there's small communities, there's potential for ongoing interaction. People might have been flowing in or just have very transient interactions, right? And suddenly, like, I need to talk to you in 6 months. Who were you? So walk us through like some of the retention, challenges, that you were encountering running your stroke trials and some of your reflections on that.
Yeah, so I think I've heard this theme all through yesterday, and I'm going to kind of reinforce it today, especially when we're talking about missingness of data, is the relationship starts the second the patient arrives at the hospital, or the family is contacted when the patient arrives at the hospital. Sometimes even before then, actually, if they're being shipped in and we know that they're being shipped in. For thrombectomy procedures, a lot of the times you don't actually need consent because it's considered an emergency procedure. We made sure very early on that family was being contacted just as part of clinical care. When I took over as the acute stroke trial director, and I come in, I talk to the family, I set up the relationship to say, hey, you're going to get called from a number you might not recognize. That's going to be my clinical research coordinator. Her name is so-and-so, or his name is so-and-so. They work with me, and that they know that we are together. We are not separate, because you don't want to send a 25-year-old into the middle of the emergency department, and they're like, well, who are you, right? After they've been talking to doctors the entire time. So we tried to get them to kind of see us as a team from the beginning, and see them early, see them often, even if we're not actually doing anything. If I'm going to the hospital to get a Starbucks, I'll go up to the ICU and say hi, check in, how are you? A lot of the times I'll even offer them my cell phone if they're feeling very overwhelmed. These aren't necessarily high enrolling studies, but they're very traumatic, right? Somebody comes in with a large vessel occlusion stroke, a lot of times the patients are cognitively disabled as well, and so it's a lot for the family, I think, in that moment, and so we try to be very supportive of them in that capacity. So I think building that relationship really early on is really important, and then most of our acute stroke studies go out to about 3 months. That's kind of like our time frame in terms of the primary endpoint for most of our studies. Major props to people who have to follow patients much longer than that. I will tell you, I was a site PI of Captiva. Somebody had mentioned that the other day, a secondary stroke prevention trial. That's even harder. So it brings its own challenges, but yeah, that's kind of what we're doing.
No, I think that's a great point. I mean, on paper we separate recruitment and retention, but it sounds like you really thoughtfully embedded retention right at the beginning. I want to say something that's really important, right? Emergency consent is a double-edged sword. On one hand, you don't need consent. On the other hand, by its very nature, there's not that opportunity to build what we psychiatrists call a therapeutic alliance. And you've kind of figured out how to work around that. Tell us a little bit more. You mentioned families, and families are really an important part, because you don't sometimes know what someone's cognitive status is going to be 6 months down the road. So how do families react, right? You've done an emergency consent. Oh, by the way, your loved one's in research, and great to meet you. So how do you navigate some of those difficult, very high-stress conversations?
So actually, just to clarify, the clinical part of it can be emergency consent, but the research part, with the exception of one stroke trial to date, is all still consent up front. There's only one intracranial hemorrhage study that's using EFIC right now, fastest, which is the PI of. So I think even getting from the clinical perspective, us to always reach out to family up front, kind of help that become more part of our routine practice, is what I was trying to say. What was the second part of your question? Sorry.
So let's just thinking about families, right? So let's say you're reaching out to them. Sometimes families make it to the ICU. Sometimes I would imagine you're calling them over the phone. It must be a very different type of approach when you're calling and talking to somebody that you have never seen face-to-face either.
Yeah, I think our keynote speaker was really interesting when she was talking about in PPMI how the patients were willing to travel for a lumbar puncture. To me, I am always shocked at how patient family members, I would say the vast majority of them, they keep it together emotionally, they're holding it together, they really just appreciate being in the know. I think that's the number one thing that I've taken away from doing acute stroke research, is they're so appreciative of somebody reaching out to them, trying to explain in layman's terms what's going on, explain the clinical part of it, and then kind of introduce the research part so that they know everything that's standard of care that's happening, and they have time to digest going to call you back in about 10 minutes. I just want you to digest, contact whoever you need to contact. You can even have them on the phone while I'm talking to you, and then we'll talk about research. And that kind of stepwise approach has worked really well for us.
So it sounds like a very thoughtful, integrated conversation that kind of, is adjusted to that particular family dynamics is really critical.
Yeah. Somebody's great niece is a nurse somewhere, they want to be part of the conversation, yeah, get them all in.
Yeah, that's great. Well, Nicole, you must talk to some family members here with kids. Tell us a little bit more, what happened? You started sharing with me that you're starting to follow these kids outside the hospital. So obviously the parents have to, I guess, be involved. What are those conversations like for you and your study team?
I think, similar to Yasmin, it's developing that relationship from the moment that you hit the hospital. Our team there, it's a different cultural community, but that community says, we're bringing you into our family, which is how the research team words it exactly, which makes a lot of cultural sense to the Congolese, that okay, you're here for me, I'm here for you, we're in this together. And so, during the acute phase of their hospitalization, we really do treat them as if they are our family members in terms of when we have a result that we're able to share with them, we share it, we explain it, we talk to them about their child's care, which is a little bit different perhaps than how medical care traditionally goes throughout a lot of Africa. And so I think most families pretty quickly see us as their ally in participating in the wellness of their child, which that's everybody's objective, is for their child to get better. And so we do develop, it's an acute study, they're all acute studies mostly to date, but it's still developing that therapeutic alliance. Because the stakes are so high, you can actually do that probably with therapy. But yeah, so we are moving towards doing longer term follow-ups. Things look quite different there in terms of follow-ups. Oftentimes, transport will be a problem, and so we routinely have to pay for transport costs for the families to come back, or they will not come back. So we have it set up where they have mobile money on their cell phones, and when it's the day for them to come back, our study coordinators will send them mobile money on their phones, which then they can use the mobile money to get the motorbike taxi, so they can come. That helps facilitate patients coming. I think similar to other studies, if they fail to follow up, we'll attempt a phone call, but the cellular surface there changes a lot. People will get rid of one number and get a new number regularly. And so at the time that patients are coming to the hospital, we take and there's also no addresses, right? So you can't say, I live at 180 South Roosevelt Street. So we take what's called verbal maps from family members while they're in the hospital. So it's like something like, go down the street to the Catholic church, turn left, go past the fish ponds, enter to this location, go to this village, ask for this person, and we'll be there. And I know that sounds crazy, but even in patients that we cannot reach them by telephone, sending someone on that verbal map to find them, we have almost a 90% success rate at following up with families. And we know, as they're giving us the verbal map, we make it clear to them, like, hey, if you can't reach us or we can't reach you, we will likely come to find you. Do you consent to that? So that it's not a surprise if someone is just showing up at their door in the middle of wherever. So it was a slightly different approach, perhaps, than what might make sense elsewhere, but I think thinking outside of the box for whatever might work in your setting would be the take-home message from that.
Yeah, that I'm really glad you brought up, our natural intuition practice is more of a Western cultural concept, is that the person is autonomous, they make their own decisions, nobody else should be involved. It sounds like these are very group decisions, and we've had the same experience, in the ADRC with our African American Black communities. A lot of our older folks don't keep cell phones, and they're actually just like, call my family members. But then it's a little interesting in an integrated way. They're like, but don't tell me anything else other than that, they're my conduit to reach me, but don't tell them what it's for. I was like, oh, okay, this is fascinating. So it's really great to see, how the parallels, are are coming through in some ways. The other question I have, which I'm so fascinated by, is the role of the village leaders, right? In terms of the research, and I'll be curious to also hear from you as well. Like how, because you get people from different areas of the country geographically. But like in some cultures, right, the rabbis or other key figures play a huge role in the medical decision making, and I would imagine this is clinical research, that type of decision making. Did you find that to be the experience that, it's not just like, hey, we're pushing research. The village leaders are actually intimately involved in the clinical research decision making process, both within the hospital and after they leave the hospital, and as you try to retain these individuals in your study?
Yeah, absolutely, without a doubt. Unfortunately, my general intuition in picking the first couple of physicians that seemed to be invested in research was correct. And so out of the gate, they were like, from the beginning, the village chiefs, you have to get and keep their buy-in to this. And so one way that we've done it is every 6 months, actually, we bring the village chiefs back in for a one-day update, where we review any results of any work that has been done. We look at, like historically, this was the rate of mortality, this was the rate of, kids leaving the hospital with severe neurologic disability. Here's what we've done so far. Here is why we're doing this, because we're finding these changes. And then after we have that buy-in from them, the village chiefs themselves help us craft the radio messages that we'll put out to the community for that next period of time that highlight some of the response or some of the results that we've had, as well as upcoming opportunities.
Well, that's really great. That shows once again, like really sort of community-driven messaging. So I think I want to move on to our sort of final topic, because I want to make sure. I think we talked a little bit about pivoting, whether it's a vision, for your career and clinical trial. And Yasmin, I think you're at a very critical point in your career, right? You're thinking, about, how can you sort of get your, first sort of fully launched trial. Tell us a little bit more. I think people, in your role as now director for, stroke trials, how did you get to that position? How is that helping you? How does that help you better understand, the challenges, right, as you sort of now, sort of head from early to, more mature part of your career, heading towards mid-career?
It's experience, I would say. So I think getting us as fellows, getting your trainees to be excited, what is drink the Kool-Aid, is that what people say? Drink the Kool-Aid of clinical trials. That's where the rubber meets the road. That's what we need to kind of change practice. I think once you get that buy-in from your team, people are really excited to go out of their way to help, right? Like, people are willing to leave their houses at 10 p.m. to go to the hospital, to talk to people face to face instead of trying to do everything by telemedicine, right? Just to be more personal. That's the kind of buy-in. I mean, even now with our fellows, we have every month now, we have mock enrollments for our key stroke trials. Practice the language, we do role plays all the time where, you're the sister-in-law who's like not a believer in research, and you're the wife, and you really want, your husband to do this, but you're not so sure. And how do you navigate that dynamic? When you practice in a safe setting, you get people used to kind of mitigating certain situations, and seeing somebody who's kind of a champion, somebody who has more experience mitigate those situations, then you can kind of pick up on key phrases and things to learn to help navigate those situations. Also, stroke is changing rapidly. A lot of our studies are not just parallel or catheter-based trials, so to practice using that language and to convert it into layman's terms, it can be kind of challenging. So we practice, get the experience on the floor of actually doing it in real time. I think that is so important. I mean, there are certain times where I read trials, feasibility studies, and I'm like, that's going to be really hard to pull off in real time. That's going to be really hard to pull off here specifically.
doing things, even though acute stroke is definitely doing things a bit on the fly, but from the recruitment and retention and standpoint, you really sound like integrated, going ahead and practicing. That's really great.
If you don't know that you look like you're the expert when you're talking to them, they'll see right through that.
Well, that's definitely true. Even if you are, they'll definitely check it out. So, Nicole, sort of, you're a little bit more advanced in your careers than some of these. Just on the final note, what would be one thing that, looking back, that you might have maybe done a little bit differently from a vision sort of career standpoint, as people, will one day, be a full professor. So just one thing you would have maybe done slightly different, or maybe completely differently. I don't know.
Probably started my career earlier, but I'm going to start with something that I would do the same, and then contrast it with something I would do different. So one thing that I have learned, the settings that I work in are difficult, and persistence is important. And I think that's true of a lot of us. So I would keep up with the amount of persistence that it took to build. I now have 7 research sites, 4 in Congo, 2 in Zambia, and tagged onto an existing site in Malawi. But it took an enormous amount of persistence and grind, frankly, to execute that and get these sites up and running and functional. I think probably something different, because my research probably looks a little bit different than most people. I think my mentorship structure has looked very different probably than most people. At times it was non-existent, at times it was someone that was peripherally involved in something that was related or. And I probably would have worked harder from the very beginning to come up with multiple people to form a mentorship team that kind of filled all of the different aspects of the things that I was looking for, instead of just kind of slowly picking up one at a time. It's just being a bit more thoughtful out of the gate to organize that team.
Well, I think you've shown amazing strength in still wanting to learn and be persistent throughout this part of your career, because usually, people at your stage are like, I'm done learning, I'm ready to mentor, but, I think you've recognized the value of good mentorship. I think I want to make sure we have a few minutes, we have about 5 minutes, because I always like to finish on time for this one when we go first, so at least we have both sessions started. But I want to make sure we took some questions, share some reflections, just go ahead and speak up. So, yeah. Yeah.
So, this may be more for Sophia than the other.
Okay, so I'm going to get okay.
So, I wear a couple different hats. One of the hats is for 10 years I was vice chair of the IRB. So, I'm always struggling with therapeutic misconception that when you recruit someone into a study and you're their doctor, how do you faithfully let them know that the research really has equipoise, you're not sure it's going to benefit them, but they're trusting you to actually take care of them potentially at the same time?
Yeah, I don't think that's even a clinical trials specific question. We have this problem at the ADRC. Jared and I, we see people in clinic, we see them for research studies. So there's no right or wrong answer to make sure, and that's the plus side about having the integrated conversation from clinical to research. It helps them understand, but then you run into the sort of ethical issue. So there's a couple of different ways to approach this, but I think one thing is to introduce them, I think, to the recruiter and making it very clear what the recruiter can and can't do. I think in the ADRC, we actually, except in pretty rare cases, we try to actually switch up. I think it's good anyway, because the way we have things set up, we want to see what a different clinician thinks from a research standpoint. But when possible, we actually try to switch up, because they know that there's an entire team behind us. But I can tell you that it takes repeated reinforcement, even in an observational setting. I can't tell you how many people come to our ADRC, which is strictly observational, and thinks that we're going to give them leukemia. We get tons of phone calls, and so we have to call, we have to explain to them, no, you have to go to clinic. I can tell you that for us, ethically, it's an equipoise issue, but for underserved communities, it's the money thing. And then they get really angry at us when they don't realize, and they get a bill. And that's when people call up and they yell at us. And even though we've explained it to them a million times, this is why I think it's really important, especially depending on the cognitive status of the individual, or in some cases, the neurologic status, that you get family involved. Most people are not going to come by themselves. And I think making sure another individual understands, but you can be as transparent as you want. You can sit there and explain it. It's hard for people to get, especially when they're sick. Get somebody else involved. Be transparent with the entire family. Because it's also, when they get the medical bill, the family member who's going to be opening the bill is sometimes the ones leaving the angry phone messages that I have to address. So that's a great, both practical question and deep ethical issue.
Thank you.
Okay. Does anybody else have questions? I guess maybe I didn't take any questions. So many people want to grill me instead. I know all of our questions. So, we got 1 minute before I think that.
I just have a quick question for Yasmin. So I'm from southeastern Kentucky, but I live in Pittsburgh, work at Pitt. But I was just wondering if you've done any mapping about who participates from what geographic areas to try to maybe target a little more to really enrich a bit more from rural areas. I know there's a big push to do more with rural, but and what misconceptions there are with research and experience.
Yeah, I think the issue with acute stroke is you get shift wherever the local EMS takes you. Now, the telestroke network of UPMC is much bigger than the telestroke network even of UC, which is still quite big. So it's hard for us to specifically target those areas without having a freestanding business relationship with those areas. I would say on the retention side of things, knowing where your patients are going and where their PCP is, a lot of these trials will say, this vet or assigned vet PI wants to go to this person or this person. Just pick up the phone and call their family doctor. These are the people in rural areas, the family doctors are true family doctors. They're doing, the real bread and butter work in the community. Just call them, talk to them, tell them what happened. It goes a long way. So, yeah. Doesn't answer your question, but that's the reality of the case, unfortunately.
Great. I want to make sure we end on time, so thank you.